Oh, it's 7. So I think, Mel, we've started recording. We have a wonderful group on. Hello, everyone else who just came on. I'm just going to share with everyone before we start. We have a Q&A, and feel free, please, to post in any questions. Melissa's going to move through her opening. She has a PowerPoint presentation, and then at the end, she might do a quick syllabus on the course, but the lion's share is going to be on her content. Pop in your questions, and then at the end, 45, 50 minutes, I'll ask the questions to her so she can just flow through her content. But please pop in any questions as we move along, and I'll see them, not to worry. Mel, we've got a good group on now, so you're welcome to start.
Okay. Hi, everyone. Welcome. First of all, let me thank you for taking the time to come in and join us on this webinar. I know how difficult sometimes it can be to find the time for these things, so I really appreciate that you've taken the time out of your day to be here for me. And I am super excited to be talking a little bit about mental health today, and then talk a little bit about the upcoming continuing education course we have coming as well. To give a little bit of background about myself as how I got here, as I was graduating from IHN in 2016, I had a little bit of what does this all mean? What am I doing with this? Where am I going? And I knew what I didn't want from my career, and I knew what I really did want. And what I really did want was to be able to help people on a really grand scale, on a larger scale. And I knew I wanted to do that through clinical practice. Much like many of you and how we come into IHN, I came into IHN through my own struggles with mental health and learned to work through those in a natural way. After I graduated, and while I was finishing up my co-op placement and working full-time at Healthy Planet, this job opportunity came up through IHN at the Canadian Health Recovery Center. And as soon as I saw it, I knew what a very special opportunity that it was. So not knowing if I qualified or not, I went ahead and I applied. I started there about 3.5 years ago in a part-time position. And my goal from the moment that I got in there was to show the owners and the clinical director and everyone else that was there the potential for that program. So Canadian Health Recovery Center is a private treatment facility for men with addiction, but also mental health disorders. And of course, with addiction, quite often there are the concurrent mental health disorders that we see. So currently it's an inpatient program, it's a private facility. And a lot of what we do focuses on whole natural health without prescribing psychotropic drugs. We are holistic at its core in that we do have a medical doctor on staff, which allows me to do a lot of blood work analysis. But the first line of sort of addressing things is always from a natural perspective. So we're working with psychotherapists, yoga instructors, personal trainers, 2 nutritionists going to be on staff, and of course chefs as well. So really, really special place. I've gotten to work with over 400 clients in about 3.5 years. So it's been a real whirlwind. And about 1.5 years ago, I took over as director there. So we're going to get going on our presentation for tonight. And we're going to be talking a little bit, like I said, about mental health. I'll load that up here. Julia, can you see that?
It looks good, Melissa.
You can see it? Okay, good. All right. So when we're thinking about mental health, it's a very exciting time for us currently as practitioners. Because as people are starting to begin to talk more about their own mental health, we're starting to see a shift where people are looking for more natural ways for managing their own mental health. Years ago, if you asked somebody about mental health or if they struggled with mental health, it'd be very hard to get somebody to open up. but now we're seeing people beginning to talk about it a lot more. It's becoming more commonplace. And with that comes more of an opportunity for us as natural health practitioners to really help people navigate and understand what is going on in the body from a biological level that is contributing to a lot of these things that people are experiencing. Sorry, let's go back for a second. I'm a little technology challenged at times. I'm going to give a brief outline here of some of the things we're going to be talking about. So we're going to open up and talk about Alzheimer's disease first. And this is one of the topics that we cover in the continuing education course. Now, when we are talking about Alzheimer's disease, we know a lot, or we think we know a lot, about some of the contributing factors. We're going to look at the hallmark characteristics. We're going to look specifically at the role of acetylcholine and some genetic considerations that maybe we haven't thought about yet. Looking at depression, looking beyond serotonin. So understanding that depression is not always a serotonin problem. There can be other things going on there as well. Generational bacteria. So looking at how mental health can often begin in the womb, and the bacteria that gets passed down can often set the stage for much bigger problems later on. We're going to look specifically at a case that came into my private practice a little over a year ago, because often when we're looking at these things, it's, you know, we study depression, we study anxiety, but what does that actually look like in clinical practice? What do some of these symptoms present like? What are some things that we can look for? And then we're going to be looking into identifying food sensitivities for improving mental health outcomes. Getting into Alzheimer's disease. So Alzheimer's is the most common form of dementia. And there are currently about 500,000 people in Canada living with some form of dementia. And there are several theories as to what causes the hallmark characteristics of the disease. And currently, the focus is primarily on prevention. While it is well understood that the changes in the brain in the Alzheimer's patient are quite profound, often we'll see the clinical presentation come way after those changes have started to take place. There's a multitude of factors to consider that contribute to this disease, including genetics, lifestyle, and then also nutrient deficiencies. So we're talking about hallmark characteristics. We're talking about things that can commonly be observed with the Alzheimer's patient. So we all are very familiar with beta amyloid plaque buildup that happens in the neurofibrillary tangles. But some of the other things that are observable are decreased levels of acetylcholine. We're going to see shrinkage of the prefrontal cortex, specifically the hippocampus. There's free radical damage to brain cells. And there's also a loss of insulin signaling on the neuron membrane as well. So free radical damage and high homocysteine levels are one of the things that are thought to contribute to the resulting inflammation and the decreased neuronal signaling. And then there are three theories that support the development of these characteristics that are currently circulating. One would be in the cholinergic theory that we're going to be exploring today, type 3 diabetes theory, and then also free radical theory. When we're talking about the cholinergic theory, we're going to be looking specifically at acetylcholine and its role in the hippocampus. So the hippocampus, it assists with the storage of long-term memory. It's responsible for the memory and location of objects and people. It converts things that are in our mind at the moment, which is short-term memory, into long-term memory. So things that you are going to be learning from this presentation, it's going to be the hippocampus that's going to help you store that into fat for long-term memory. And acetylcholine is a neurotransmitter that supports and modulates different types of memory. And cholinergic neurons densely innervate the hippocampus. And what I mean by innervate is that they supply the nerves in the hippocampus. So how this presents in an Alzheimer's patient is when they have damage to this area, they're not able to store any new memories. So old memories before the damage had taken place still remain intact. Well, anything new, they're unable to remember. So they may be able to remember what they did at the age of 6 or 26, but they may not be able to remember a new person that they met last week. So the cholinergic hypothesis examines the role of acetylcholine in the development of Alzheimer's disease. And there is a marked decrease in acetylcholine. And the cholinergic hypothesis suggests that a contributing factor to Alzheimer's disease may be due to choline deficiency and reduced choline synthesis. And there are several factors that can contribute to this acetylcholine deficiency. So if we look at the transport system that actually transports acetylcholine or choline into the brain, after 55, we see a decreased ability for the brain to be able to do that. The mechanism becomes actually less efficient. So it's harder to get choline into the brain and across that blood-brain barrier. Choline is thought to be kept in the choline pool, especially in phosphatidylcholine. And it's there and stays in storage prior to being incorporated into acetylcholine. So it's being stored as something called phosphatidylcholine. And phosphatidylcholine, of course, being a very important phospholipid and really important when it comes to neuronal signaling. So when we're actually looking at acetylcholine synthesis, we're going to look at that in a minute, and we're going to see where phosphatidylcholine comes in with that. So the transporter becomes less, as the transporter becomes less efficient, choline stores from that phosphatidylcholine pool become depleted. There's also anticholinergic drugs to consider as well. So anticholinergic drugs, these are drugs that block the effect of acetylcholine in the transmitter, and these are common drugs that we'll often see. So things like Benadryl, which is an over-the-counter drug known to have these anticholinergic effects. We'll also see these prescribed antipsychotics, so things like Seroquel. I see Seroquel being prescribed a lot in private practice, not only as an antipsychotic, but sometimes I'm seeing it also being used as a sleep aid. Antihistamines as well would be another common one that we would see coming up with that. We also have to maybe consider genetic errors in choline synthesis as well, and specifically the PMT gene. And that gene codes for a transferase enzyme, which converts phosphatidyl, I'm really bad with this word, phosphatidylphenylalanine into phosphatidylcholine in the liver. And the C allele variant carriers have a reduced ability to actually synthesize phosphatidylcholine. So when needed, choline can actually be cleaved from phosphatidylcholine and can be converted into acetylcholine with the help of acetyl-CoA. With people with this variant, that's not happening very well. Then there's also the CHAT gene, and the CHAT gene encodes for acetyltransferase, and it acts as a catalyst, and it's transferring the acetyl group in acetylcholine. And what we're seeing is these polymorphism changes in this gene with reduced CHAT levels. So with acetyltransferase, that is the enzyme that is responsible for taking acetyl-CoA and choline and converting it into acetylcholine. So what this gene does is when they have this morphism, is we're no longer producing enough of this acetyltransferase, and we're having a reduced ability to actually produce acetylcholine. Other considerations, so some studies suggest that the amyloid plaques in themselves actually reduce the effectiveness of acetylcholine in the neurotransmitter, and actually reduce the ability of us to be able to produce that acetylcholine transferase enzyme, so it seems to downregulate it. And this enzyme, what I'm also seeing is an increase in the enzyme that actually breaks down acetylcholine as well. And when that breaks it down, it's breaking down to acetate and choline. So the most popular Alzheimer's drugs actually work on this pathway to slow down the enzyme that's breaking down acetylcholine. Unfortunately, though, it doesn't seem like long-term that these drugs tend to be effective. So the other consideration we need to look at is choline deficiency in itself as well. If we're looking at our aging population, we're coming out of a time where people were scared to eat eggs. You know, they were told to avoid eggs because of cholesterol, and cholesterol is bad and fat is bad. So often our aging population is coming from a belief that a lot of these foods, like eggs that contain high amounts of choline, are actually not very good for them. So choline deficiency would be something we'd want to look at in the aging population with that in mind. Also things like a vegan diet. We may want to look at choline levels, as there's not a lot of choline coming in from a vegan diet as well. So supplement consideration. So daily recommendations for anyone for choline, according to with Linus Pauling, is about 555 milligrams for men and about 450 milligrams for women. After age 55, 1,000 milligrams a day may be beneficial for protecting against mild cognitive decline. And CDP choline may be a really good one to consider here, as CDP choline is the last intermediate in the phosphatidylcholine synthase. So there's a couple of different ways that acetylcholine can be made. One way is through the methylation pathway, and another one is through the CDP choline pathway. So by supplementing with CDP choline, we're helping to synthesize phosphatidylcholine very easily. That is the last intermediate in there. Huperzine A. Huperzine A has actually been approved to treat Alzheimer's in China. And its mechanism of action is what it does is it actually inhibits the enzyme that breaks down acetylcholine, which is acetylcholine esterase. It looks to protect the nerve cells from some of the neurotoxins, especially L-glutamate, and protects the neurons against amyloid plaque-induced oxidative stress and apoptosis, ameliorates mitochondrial malfunction by reducing free radical damage as well. So when we're talking about apoptosis, of course, we're talking about cell death. And that's partially what we're seeing when we're looking at that shrinkage in that prefrontal cortex with Alzheimer's disease. So often huperzine A is used with other supplements, something like acetylcholine. Phosphatidylserine might be another one we might kind of want to consider as well. And we're going to be talking about this in more depth with the continuing education course. So looking at depression, when I talk to my clients in private practice about depression, what I want to start them to get them to understand is that depression is often a symptom. So if we go see our doctor and we say we can't get out of bed, I'm crying all the time, I don't want to do anything, he's probably going to turn around and say depression is present. And that's often sort of the end diagnosis. They prescribe, an antidepressant most likely, or an SSRI. But what I like to look at when I talk to my clients, I like to talk to them about depression being another symptom. So when we're talking about symptoms, it's about finding the underlying reason why the depression is there in the first place. So often there is a biochemical reason why the depression is there, and the body, through how it expresses the depression, is giving us clues as to what the imbalance may be. And a lot of time what we'll see is depression can fit into some biotypes. So when we're talking about depression, we're talking it as a broad term. We're looking at to describe things like bipolar disorder, substance-induced mood disorder, seasonal affective disorder, even postpartum depression. And typical symptoms include sadness, feelings of worthlessness or guilt, social withdrawal, agitation, problems with concentration, even difficulty sleeping. And of course, at its absolute worst, we'll see suicidal ideations as well. And as we kind of dive in, we'll see that there are certain biotypes that are prone to certain behaviors over other biotypes. So the depressed population, when we're talking about these biotypes, can often be divided into 5 different chemical classifications. So we have our undermethylated group, copper overload, folate deficiency, pyrrol disorder, and then also toxins playing a role in there as well. So Each biotype, as I said, exhibits its own symptoms, traits, and physical characteristics. And when we're looking at the traditional method for treating depression, which is an antidepressant of some sort, whether that be an SSRI or an SNRI, about 30 to 60% of the population are not helped by antidepressants. I often get clients in my office who have tried a multitude of antidepressants or have one antidepressant stacked on top of another. And I'll ask them, how is it working? How do you feel on that? And often they're saying, you know what, it's not working for me, or I think it might be working, but I'm not really sure. And that's often because it may not be an actual serotonin problem that's going on. So it's important to understand depression as a symptom and looking at the different types of depression and the different symptoms that are being produced when we're trying to address depression, to dig a little bit deeper and see what might be going on. So in the undermethylated group, what we'll often see is reduced serotonin and then also a reduced dopamine as well. And the folate deficiency, we'll see elevated serotonin levels and elevated dopamine. With these biotypes as well, we're going to see that specific ones with endomethylation and folate react very differently to SSRIs. Copper overload, we're going to see elevated norepinephrine, pyrrol disorder, reduced serotonin, but also reduced GABA as well. So what's going on with pyrrol disorder when we're looking at the deficiencies that are there, it's kind of a double whammy. And so with the pyrrol disorder, we're not only getting the depression, but because of the reduction in GABA synthesis, we're also getting severe anxiety as well. So these characteristic difference in these biotypes can largely be attributed to the effects on the neurotransmitters that they are acting on in themselves. So the undermethylated group, what we'll see with the undermethylated group is they tend to have a good response to SSRIs. So these are people who get put on an SSRI and they often do very well with them. They're the ones that respond very quickly to it. They tend to have an adverse reaction to folate, and we're going to explore that a little bit more. These people tend to struggle with addiction, non-compliance with therapies. I know what you guys are all thinking right now. That's just about every client that I have. So these guys often, not only are they non-compliant, but they also have a hard time admitting that there is an actual problem as well. So these may be people who have a hard time actually saying that, yes, I'm depressed. Even when you talk to them, they are showing classical symptoms of depression. I see this a lot in practice as well. I'll often sit me down and talking to a client and talking about their symptoms, and we'll talk, things like what they do for self-care, and you may say, you know what, I don't really do anything. I said, okay, what do you really love to do? And I'm like, well, I don't really do that anymore, or anything anymore. I can't be bothered to really do these things, and that in itself can be a sign of that depression. So these guys often have a hard time even understanding that they are depressed. They tend to carry a high inner tension. This group tends to have higher suicidal tendencies, and they tend to be very strong-willed as well. So when we're looking at methylation, methylation is an important action that's happening in the body. And it's important for many different things, including regulating protein, gene expression, and even the synthesis of neurotransmitters. And imbalances in the methylation pathways from genetic defects, which regulate the process of methylation, specifically mutations to the MTHFR gene, can affect our ability to either undermethylate or overmethylate. So when we're trying to decide if a client is overmethylated or undermethylated, yes, we can run testing, look for that MTHFR gene, but at the same time, we may want to also consider histamine levels, and specifically whole blood histamine levels. If you have a doctor that is willing to work with you to order that, can be a really valuable test. Not the cheapest test on the block. I think privately through the labs, it's about $236 through either Dynacare or Life Labs, but it can be really valuable for helping to determine the methylation status. These guys will often show classic signs of serotonin deficiency. So the undermethylated depressive group, they tend to be folate intolerant. So if you were to put them onto a folate supplement, they're generally not going to do very well. They tend to be low in both serotonin and dopamine. And largely why they become folate intolerant is that the folate actually increases the expression of the transporters of serotonin. So we're getting more serotonin that's happening. It's a sorry, I'm just going to grab some water here just for a second. It's a reuptake promoter. So very similar to what an SSRI is doing, is that it's allowing that serotonin to stay longer in the synapse. So in contrast, SSRIs are also the inhibitors. So when we're having this folate that's coming in, it's promoting the reuptake of serotonin, whereas the SSRIs are inhibiting it. Hence, these clients tend to have a favorable response to SSRIs because they tend to be low in both serotonin and dopamine. So with the SSRIs, they're keeping the serotonin longer in the synapse. Undermethylated depressants can also exhibit some degree of pyrrol disorder as well. So sometimes we'll see a sort of a double biochemical imbalance going on. But really important to maybe consider what's going on when we're thinking about doing folate supplementation with somebody, because specifically because of the expression, the role of folic acid or folate on the transporters, we may want to reconsider that. These people, when we do supplement with folate, tend to get worse. So when we're looking at folate, next group, we're looking at folate deficiencies. And most depressants of this biotype also report a high amount of anxiety as well. They often have a history of ADD or ADHD, underachievement in school may be present. And in contrast to the undermethylated group, these guys tend to have low histamine levels. And deficiencies can result from mutations in the MTHFR gene, low intake of folate, inflamed gut, or digestive disorders, affected absorption, excessive alcohol intake as well. So alcohol, as we know, depletes those B vitamins. These guys tend to have adverse reactions to SSRI treatment. So when we're looking at this particular group, these guys have too much or don't have a serotonin deficiency. So when we add on that SSRI, we're increasing those serotonin levels, and we can get symptoms of starting to come up of serotonin sickness. And one of the most common that we'll see start to come up is things like nausea, vomiting, and that's because serotonin, we know it as a mood modulator, but it also works in the gut as well as a digestive modulator. So we'll often see those symptoms coming up with it as well. With these clients, it's important to try to avoid tryptophan and 5-HTP because their serotonin levels tend to be higher. We may want to consider folinic acid here since it easily crosses the blood-brain barrier. Pyroluria. Pyroluria I see quite a bit with clients coming in with severe anxiety, and they don't really know when the anxiety began. So these are people, when I start talking to them about the anxiety, they'll say, you know what, it's just kind of been something that's always with me. It's just this thing that's kind of sitting in my chest, sitting in my stomach. And as we kind of go back and we start talking with them, we can often trace that back. And what we'll see a lot of the time with these clients is they say, I think it may have started around grade school, you know, maybe around 10 or 11. And I'll ask, okay, what was going on in that time? And I say, oh, my parents divorced at that time. So we're seeing either a stress or we're seeing a trauma that's triggering in this pyroluria disorder. And that's because it's a genetic disorder. And what it's resulting from is too high are these pyrrol levels, and these elevated pyrrol levels are creating this chemical imbalance where they're making zinc and B6 unavailable to the body. And we can do a very simple urine test to test for these pyrrol levels. We can also supplement with zinc and B6, and they will often see if we suspect that it's pyroluria or pyroluria depression that these clients get better really quickly. I can often in clinical practice pick one of these guys out very easily. They tend to have no ability to handle stress, with any stress making their anxiety even worse. History of ADD, ADHD, severe mood swings. We may see an inability to recall dreams. And interesting, once you add in B6 back in, they'll start to remember dreams. They'll start to dream again. They may have problems with rage. They have a tendency to skip breakfast, and they tend to be very nauseous in the morning. So when they do eat, they don't feel well. They tend to be fearful, pessimistic, tendency to isolate from others. And often what I see more often than not is a history of alcohol addiction in the family. We may even see a history of schizophrenia in the family as well. But quite often that history of addiction, specifically alcohol, often is there. Along with the deficiencies in zinc and B6, we'll also see an increased levels of anhydric acid in there too. Generational bacteria. So when we're talking about generational bacteria, we're talking about the microbiome that gets passed down. So when we're talking to our clients, we often spend a lot of time asking about their digestive systems. We spend a lot of time wondering what is going on within theirs. We may order testing to see what's going on. But how often when we actually sit down with clients, do we actually dive in a little bit into what their parents' microbiome is, and especially the mother? Because when we're looking at somebody with long-term mental health issues, digestive issues, we got to wonder, where does it all begin? And often that can be traced back to the mother. And even the father can have a role in that microbiome as well. So when we're looking at this particular class of client, we're linking common psychological symptoms into digestive issues. Specifically things like ADD, ADHD, autism, even schizophrenia can be put here as well. And when a baby is born, a baby is actually born sterile, and the mother passes their unique microbiome onto the baby as the baby goes through the birth canal. Now, the problem, what we're facing now with a lot of modern mothers is if they're born between the 60s and the 80s, they were generally not breastfed, because at that time, that's when infant formula started coming out, and it became trendy to be able to afford the formula and to feed the baby formula rather than having a breastfed baby. Luckily, we're seeing a shift coming back, and we're seeing babies being more tending towards being breastfed. We often see mothers that have had years and years and years of birth control before actually having conception. Especially now, we're seeing a shift where women are deciding to have babies later in life. So they're starting to focus more on career, babies later in life. So there may have been years. And what we know with those birth control pills is that they do alter a lot of the microbiome. So the mother themselves often show signs of dysbiosis, and that could be digestive issues, PMS, headaches. And if the dysbiosis is in the gut, we're also going to find dysbiosis in the vaginal flora of the mother as well. And as baby travels through the birth canal, they become exposed to these improper bacteria. Breastfed versus bottle fed will also produce a different bacteria in there, or a different microbiome. And the gut, actually, the microbiome of that baby primarily develops over the first 20 days of life, with maturing in and around 3 years of age. And of course, this plays a key role in the development of the immune system. And when we're talking about the immune system, this becomes important as well, because we're looking at the long-term health of the child. So when we have a baby whose microbiome is already compromised, as they get older into children, the immune system does not develop properly either. And they're often at risk for things like ear infections. And then we'll see with the prescribing of antibiotics, we'll see an increased dysbiosis that's happening within that gut biome. Gut flora, of course, needed for proper digestion and synthesis of key nutrients. So this often leads to malnourishment and nutrient deficiencies. And without healthy bacteria in the GI tract, we can't function properly. It can't function properly and do its thing like digesting and absorb. So when we're looking at what the gut bacteria are doing, we're also looking at how the beneficial bacteria actually produce beneficial fatty acids through the digestion of fiber. Now, if we've got a compromised bacterial system, we're not going to be able to do that as well. I want to talk briefly about a case that came to me about a year ago, and this is Carter. And I wanted to use Carter tonight as an example because he's a really, really good example of someone where the gut is really tied into what was going on with Carter. And as we go through his history, you'll kind of see that there of how that fits into some of the things we were just talking about. So Carter came to me at about 9 years old. And Carter was underweight. Carter was small stature. He was very pale, dark circles under his eyes. He had a hard time eating in the morning, would not feel well after eating, especially in the morning. We ran blood work and was showing that Carter was anemic. He had high amounts of anxiety, which his mother identified, or they called as worries. Carter was a vaginal birth and he was breastfed. He had previously been diagnosed with eosinophilic esophagitis. It's an autoimmune disorder that causes inflammation within the esophagus. So swallowing for Carter at times was very hard, which even added on to the problem with Carter being able to eat. He'd previously been given many, many rounds of antibiotics for ear infections and other ailments that children come down with. I had the opportunity to also work with Carter's father. So how Carter came to me is I first worked with Carter's father when he came in for treatment, and his father stayed with us for about 6 weeks. And Carter's father had a history of addiction, specifically alcohol, but also cocaine. His father suffered with addiction, anxiety, depression, but also was found to be pyrroluric and responded very well to the pyrroluric treatment while he was there with us. And Carter's mother, and actually Carter's aunt, I also had the pleasure of working with. So I got to know a lot about the family history that was there. And Carter's mother had endometriosis and a history of tachycardia. And this was the tachycardia was determined to be stress related. And then Carter's maternal aunt also had endometriosis and high amounts of anxiety. So we're seeing, as we're kind of going through the family, a real dysregulation in the microbiome coming up not only as autoimmune disorders, and we see that running through the family, but as we kind of talked to even Carter's father, we were seeing things like long-term digestive disorders. So part of what we did with Carter was identifying some of those food sensitivities that may have been coming up, knowing that Carter potentially was one of these gut and psychology clients, as we call them. And we really wanted to identify those for that better outcome for Carter. I'm going to get a little bit more into the food sensitivity aspect, but a lot of what we did with Carter was removing things like wheat and dairy, and we're going to talk about why wheat and dairy may have been so important here. And I'm happy to report is I continue to work with Carter, but he's put on weight, he's no longer anemic, he's playing hockey, he looks really great, he's eating more regularly, and mom and dad are absolutely thrilled with the process that Carter is currently going through. So we're talking about food sensitivities. Often these food sensitivities can be coming up from these long-term digestive issues. And when we're talking about food sensitivities, Patrick Holford refers to them as something called brain allergies. And the most common that we'll often see, especially with these gut and psychology clients, is the inability to digest gluten and dairy. So gluten and dairy digestion happens in 2 different stages. And the first is in the stomach through digested juices, and those proteins get split into peptides. And some of these peptides have morphine-like structures, and they're called caseomorphines and also gluteomorphines. They're then peptides move to the small intestine, pancreatic juices are added, and further broken down by peptidases on the microvilli of the enterocytes. Now this stage, that last stage, is actually missing in people with altered gut bacteria due to the malnourishment of the enterocyte cells. And these caseomorphines and gluteomorphines get into the bloodstream and they get absorbed unchanged. And we can actually see these proteins that are detectable in people with depression and schizophrenia. So these casomorphines and these gluteomorphines are thought to cross the blood-brain barrier and block areas of the brain very similar to how opiates would work as well. And what they do is they interfere with normal neuronal function, and that's when we'll start to see a lot of these symptoms that are coming up. So when we're talking about these food sensitivities, another thing that may be really important to start thinking about is the inflammation or that response that is happening there as well. When we're talking about food allergies and food sensitivities, we're talking about that IgG response. And often these food sensitivities or these brain allergies can be really difficult to identify because they're often producing symptoms that don't pop up for a while. So it's not an immediate response, like if you have a peanut allergy where your face explodes and your lips explode and you break out in hives and you need to go to the hospital. Often what will happen with these IgG responses is that we'll see a cluster of symptoms that don't seem to make sense on their own, but when we kind of go back to these allergies, we may things like brain fog, and I'm not talking, brain fog and also chronic fatigue. And chronic fatigue looking more at the brain and the brain being chronically fatigued. We'll see a multitude of mental health symptoms, including anxiety, depression. We may see joint pain, largely because of the inflammation that's produced as well. Schizophrenia, highly tied to gluten sensitivity, and something you may want to consider when looking with a schizophrenic patient. And the connection largely lies, going back to that inflammation, in the inflammatory response to these food sense allergies that are happening. So the inflammatory response that is happening is actually very key to the immune system. And what it's meant to do is to alert us to a problem that's going on, like when we cut our finger or bang our finger, we get that inflammation that's happening and around that. And that inflammation that's there is meant to warn us to, hey, be a little careful with that area. We've got an injury that's going on there. So when we have this immune response that's happening, the immune system is the first in the gut, is actually the first one to respond. And what it's doing is telling the body, hey, we've got this foreign substance that's come in. Let's get this going, and it'll start cueing for things to have this inflammatory response. And we'll see this in the brain as well. So one of these things that these foreign substances can do is trigger, because of the bacteria that's being affected, is trigger sickness behavior. And when we're talking about sickness behavior, we're talking about how we tend to isolate when we're not feeling well. We tend to spike a bit of a fever. And that's largely because we're also meant to rest as well. And that's because we're supposed to recover from what is happening. It's an adaptive behavior that we have been taught, this sickness behavior, so that we don't spread the disease. Now, when we have this inflammatory response long term, we can often get an inflamed brain as well. So when we're talking about depression and mania, these have been identified as pro-inflammatory states. And when we look at depression, it's very similar to that sickness behavior. We'll see isolation, we'll see wanting to sleep all the time. And that's often because the brain is in this inflammatory response. It's stuck in the sickness behavior response. And a lot of the inflammation is coming from these cytokines that are spiking when we're trying to fight off this foreign substance. So food sensitivities are often caused by altered gut, especially as we're talking with the GAPS clients, and these undigested food particles causing an immune response. Yeah, I think we're definitely, we're fighting the good fight. And, a lot of the work that I do with CHRC is extremely rewarding, and getting to see a lot of these clients that are coming in that are beyond hope. As far as their own, kind of thoughts. Some of these guys are coming in from having attempted suicide recently, to have been on multiples of medications, and to see their changes over the 6 weeks to 3 months that they may be with us, and then following up with them over the time, we're seeing a huge shift with these clients that are happening. And especially when we're talking about addiction. So with addiction specific, we are looking at the body being very smart, in that what they're reaching for substances is very intelligent, in that the substance that they're reaching for is often giving them relief from the symptoms that they are experiencing. So for instance, a client that is highly anxious might reach for alcohol, because the alcohol is the antidepressant, and that's going to help with that anxiety. So something as simple as GABA with these clients can be life-changing for helping to manage that anxiety. And of course, talk therapy, CBT, DBT, very important as well. So something you always want to consider when working with these clients with mental health is working with some sort of practitioner, either a psychotherapist, an addiction counselor, somebody that can help unpack the trauma or the psychological side of what's going on. We as nutritionists are not equipped to unpack a lot of the trauma and psychological damage that is happening for these clients. Please, please, please always think about working with another practitioner in that regard so that these clients really can. Because it's not about just fixing the biochemical imbalances. A lot of time there is a trauma that is attached to it. There's a grief that's attached to it, and they need to work through that with somebody that is equipped to do that. I will not even work in private practice with somebody that is struggling with, especially addiction, unless they are in some sort of program for talk therapy.
Yeah, good advice for sure.
Mm-hmm.
Okay, Julia's on the phone again. She's busy, very busy woman.
She's a busy lady, yeah.
Why can't she unmute herself again? I don't understand.
Why can't I say things? I'm muted up. Anyway, Melissa. Thank you, Melissa. And more thank yous, Melissa. Very interesting lecture. But I can't unmute myself. It's a funny thing.
For sure, I did not mute you that time.
I bet you did. Okay. Anyways, I'm going to say bye in a minute. I'll be back, and then we can say bye. I think there's a few people left. If they have anything to ask, they certainly can. Mel, check, and I'll be right back to say bye.
Can I stop the recording now?
Sure.